Okay, let's go ahead and get started. So, first things first, VCU's annual Women's Health Research Day is coming up, and I'm going to send the information in the chat. And we would love to see all of you there, and support our lab members, and additionally potentially get an updated lab picture for our social media. Okay, and so Ivy Lab is going to CPDD. So we had both AB and Michelle have abstracts accepted as poster presentations, which is super exciting. And then Dr. Martin and I also had some presentations accepted to CPDD. And next we have our manuscripts that are in review. And most recently, these are our most recent accepted manuscripts, but we're hoping next month we'll have some newer manuscripts to share. But most recents were Shavania's, one with Dr. Martin, and Brenna's. And this paper that we submitted and got accepted months ago was finally published. So here's a screenshot of it. And here's our social media plug. Here is our Twitter. If you would like to give us a follow, we share our Ivy Lab updates on here. And we also have a YouTube channel. If you ever miss a lab meeting, or if you really enjoy lab meetings and would like to catch up on previous meetings and learn more about what we do, feel free to check us out. Okay, now getting into our active studies, we have Project Better, which recruitment is complete, follow-ups are complete, chart abstractions are ongoing, but there were a total of 37 participants, and this study provides a theoretically grounded assessment of feasibility and acceptability of a technology-delivered education intervention for pregnant and parenting people receiving medication for opioid use disorder. And AB leads this project. And here are some of the better manuscripts that are either have been published or are in review. The most recent is actually AB's paper, which is the findings of Better, which is currently in review. And then here are Better's presentations. The most recent are AB's poster, which she's presenting at CPDD, and then my presentation that I will be presenting at CPDD. And next we have Project Sword, which recruitment is complete and chart reviews are ongoing. There were a total of 211 participants, and this study investigates the relationship between sleep and opioid use disorder recovery. And Michelle leads this study. And the most recent manuscript for SWORT is Hannah and Susie's, which they presented on last week, and it is in review currently. And the most recent SWORT presentations are Michelle's poster, which just got accepted to CPDD, and Susie's, which they will be their poster will be presented at ASAM next month, actually. Here are some more of SWORT's poster presentations. There's a lot of them. And next we have the registry. So this is a retrospective chart abstraction study. There are currently 141 participants enrolled, and this is an ongoing record to track clinical outcomes of our pregnant and postpartum patients seeking addiction treatment at the OB Motivate Clinic. And AB and I co-lead this study. And here are the registry manuscripts. The most recent was Laura Ellis's. But we have some that will be coming TBD. And here are the registry poster presentations. And next we have postpartum recovery, which is a prospective cohort study that has 26 participants that were recruited. So all follow-ups have been complete, chart reviews have been completed, primary, but we have some analysis still going on with this study. And this study compares biopsychosocial factors such as pain, mood, impulsivity, and maternal infant attachment captured during the 3rd trimester of pregnancy and within 6 months postpartum between women with opioid use disorder. And this study is led by AB. And here are our most recent postpartum recovery poster presentations. So we have Victoria's, which got accepted to ACOG, and we will actually be hearing more about that next month. And then we have Ellen's, which actually just got accepted to SASCOG. And then here is the postpartum recovery manuscript. And next we have Project Castle. This study is still currently in production, but it is a computerized intervention that educates medical professionals and pre-medical professionals on substance use disorder stigma. And I lead this project. And here is the Project Castle poster presentation. And next we have the perinatal Bupe database. So this was a retrospective cohort study that was collected between 2017 and 2020. There were a total of 300 participants. So recruitment and primary analysis have been completed, but we still have secondary analysis ongoing. And this project describes trends in buprenorphine dosing during pregnancy and up to 12 months postpartum. And then here are our most recent perinatal Bupe poster presentations. So we have Carrie's, which we're going to hear more about today. And then we have Taylor's, which also got accepted to SASCOG. And then here are some more perinatal Bupe poster presentations. And then here are the perinatal Bupe database manuscripts. So the most recent manuscript is currently in review, and it is Taylor's manuscript. And so next we're going to talk about some pending research support. So we have a NIDA grant that's pending, that is titled Neural Function Phenotyping in Investigating the Role of Orexin, say that right? Yes, system at the intersection of opioid use disorder and insomnia. And then next we have a NIDA grant that is titled A Mechanistic Study of the Role of Oxytocin and Sleep Disturbance within Buprenorphine Opioid Use Disorder Treatment Sample. And then the next grants that we have that are pending are also from NIDA, and they're titled Health and Equity Information Delivery of Cognition Behavioral Therapy for Insomnia Adapted for Individuals Receiving Buprenorphine for Opioid Use Disorder. And then we have the next grant is titled Addressing Social Drivers of Health Disparities in Addiction and Intersectability Approach to Promoting Health Equity in Substance Use Disorder Clinical Research. And then I think these are the last two, but the next ones are the Jeffrey Trust Award Program in Interdisciplinary Research, and this one is titled Advancing Health Equity for Birthing People with Substance Use Disorder, Capacity Building of a Community Partnership Team for Intervention Development and Implementation Research. And then the last one is a NIDA grant that is a phase 3 double-blind randomization control trial for Subrexant versus placebo in a treatment insomnia in persons with opioid use disorder. And then we do not have our next lab meeting scheduled yet. We will be sending that out soon, but Victoria will be sharing more about her poster presentation that will be happening at ACOG. And then if you're interested in hosting one of these meetings, please feel free to reach out to me, or if you have any questions or updates.
Awesome. Thank you so much, Lilia. So many updates. It is a very busy time of year. So congratulations to all the students and everyone who got posters recently accepted. And Lilia's actually got accepted for oral presentation at CPDD. She was being very humble earlier. So we'll also be hearing from that in one of the upcoming lab meetings too. Another shout out that got left off because it's hot off the press, Brenna is matched in OB/GYN residency here at VCU. Cool. So we're all so excited about that. So congrats, Brenna.
Thanks, Dr. Martin. Thank you, everybody. I'm so excited.
Yes. Oh, I'm very excited. And then I also want to welcome Rabia to our lab meeting today too. I don't think I've have introduced you yet, Rabia. So Dr. Rabia Hanif is a clinical psychologist from Pakistan who's doing a NIDA Invest Fellowship with the Ivy Lab for this year. And so you're going to see her face more and more as she's gotten settled in and getting all her training done. So Rabia, welcome.
Thank you, Dr. Martin, for introducing me. Hello, everybody.
Awesome. Well, we're going to go ahead and Carrie, you look like you've settled. I know you're very busy today. So thank you to you and to your chief also for helping get you out of clinical duties to come present. So Dr. Carrie Shadowen is an OB/GYN resident here who's been working with us, and she was a medical student also. And so she also got an abstract accepted to ACOG, which is super great. That's very competitive. So she's going to be presenting on her research that I'll get accepted at ACOG. So any feedback too will be helpful as she is also preparing for that presentation as well as a subsequent manuscript. So Carrie, I'm going to go ahead and hand things over to you. You're still on mute. There you go.
Okay. Can you see my screen?
Yes.
Okay. Thank you guys for having me. It's really nice to see so many familiar faces. I'm sad I haven't been to one of these in a while because of residency demands, but it's good to see everybody. Yes, so excited that Brenna will be joining us, and also shout out, of course, to the other Shadowen here who defended her PhD a couple weeks ago and is coming back to med school. All right, so I'm going to be talking about this project, buprenorphine dosing through pregnancy to postpartum transition. This is a descriptive analysis. Let's see. Okay. This is, like they talked about, will be presented at ACOG annual meeting in May, and then I also presented it at our department conference in February. So as everyone knows, medication for opioid use disorder, including buprenorphine, is essential in the postpartum period, and supporting continuation of these medications is imperative through the postpartum period. But unfortunately, no clinical guidelines exist to help inform dosing, particularly changes that need to be made to patients' dosing in this very vulnerable transition from pregnancy to postpartum. So our study describes bup dose changes in the first 3 months postpartum for patients who are already on buprenorphine, and associated patient characteristics in an opioid use disorder clinical sample. So it builds on previous work that Dr. Martin and I and many others of you have done in the past. This was a paper that we published around COVID time, just looking at buprenorphine dosing through pregnancy and postpartum. We know that for patients who are on buprenorphine throughout the postpartum period, about a third increase their dose, about a third decrease their dose, and about a third stay on the same dose. We also looked at patients who transitioned to injectable buprenorphine or Sublocade in the postpartum period. This was a case series that we did that looked at specific demographics and medical characteristics and other pertinent parts of the patient history for patients who did successfully or unsuccessfully make that transition. So just a few things to point out that a lot of these patients had comorbid anxiety disorders, and just over half of them had a vaginal delivery. And then we also looked at some of their social demographics. Of course, the other Shadowen talked about buprenorphine continuation through the postpartum period, and specifically looking at patients who were on Medicaid versus private insurance versus no insurance, and then also looked at incarceration status at the time of pregnancy, indicating that patients who were incarcerated at the time of delivery were more likely to discontinue bup at a year postpartum. And that psychiatric comorbidities were very common in this population, which again, all of us know, but that people who were receiving treatment or therapy for their comorbid psychiatric condition were more likely to continue bup through the 52-week postpartum point. So our study, the objectives were to describe patient characteristics, medical and clinical variables of the 3 groups of patients that we already know about in the postpartum period. So those that have a dose increase, those that have a dose decrease, and those that remain on the same dose. So again, building on that same work that we published in 2020. And then further to evaluate how dose changes are associated with retention in treatment with bup at the 12-month postpartum point. So we hypothesized that characteristics like having an older age at bup initiation, having a comorbid psych condition, being incarcerated at the time of delivery, and having intimate partner violence may be more likely to require an increased dose. We had other hypotheses too, but this is just, one bit. So the design of the study, I think a lot of us on this call are aware of the longitudinal retrospective cohort study of pregnant patients with opioid use disorder who delivered at VCU and received bup between January 1st, 2018 and March 30th, 2020. To be in the study, they were on bup either during pregnancy or in the postpartum period. For that, parent study, the chart reviews were conducted for all individuals every 4 weeks, starting with the date that they initiated treatment on bup during pregnancy and then continued until 52 weeks postpartum or until they discontinued buprenorphine. Our study in particular investigated patients who remained on bup until at least 3 months postpartum. Our study aim was to describe qualities of each of the groups that I mentioned. So those who increased their dose, those who decreased their dose, and those who remained on the same dose. Our primary outcome was a change in the BUP dose between delivery and 3 months, which was a categorical variable with 3 levels, either increase, decrease, or no change, abstracted from the medical record. We included all patients from the parent study on BUP dosing. And for analysis, obviously I was not the one to do this because that's not my expertise, but Hannah did a bivariate analysis using Stata 17 to assess the relationship between changes in BUP dosage and patient characteristics. Chi-square test and student t-test for demographics were used and to examine the dose change. So results, this just shows our patient selection. We had a total of 66 patients who met criteria, who had complete data from delivery until 3 months postpartum. And we found that in our sample of 66 patients, about half maintained their BUP dosage the same through the 3-month postpartum point. So that was 36 patients, or 55%. The remaining patients either decreased, 33% decreased, so that was 22 patients, or had a dose increase, and that was 8 patients at 12%. These were a few nice, pretty graphs that Hannah made. So this one shows that those who had an increase or no change in their dose were more likely to continue use of buprenorphine through the 50-week postpartum point. And then we had table 1 here that shows the overall characteristics of our patient group. A few things to point out: that the most common dose that patients remained stable on and didn't require any dose changes was 24 per day, 24 milligrams per day of BUP. And then I'll also highlight that 38% of patients that were incarcerated at delivery had a dose increase, whereas 9% of patients who were not incarcerated had a dose increase. And then 39% of patients who delivered vaginally decreased their dose, and 24% of patients who delivered via C-section decreased their dose. So our conclusions: our study takes a crucial first step in developing the evidence base for individualization of BUP dosing for postpartum patients. We know, again, that this is a very vulnerable transition for patients, and that helping them have the most individualized treatment plan helps them succeed in their recovery. We found that half of patients at the 3-month postpartum point remained on the same dose, and that characteristics like mode of delivery and incarceration status at delivery may impact the need for postpartum dose adjustments. This is a first step in the development of evidence to individualize BUP dosing for postpartum patients, and highlights the need for shared decision making and taking into account the specific patient that you have in front of you when you're trying to decide what to do with patients' BUP in this postpartum period. So ultimately, we hope to use this data to eventually inform a clinical decision aid to facilitate this shared decision making that we advocate for. So again, we just hope that this informs future work to help make this decision aid, and eventually maybe we would have something in the clinic to just plug in patient characteristics to help give us some kind of sense of if they may be a patient who might benefit from a dose increase versus a decrease versus staying the same. These are my references, and this is Hannah and my husband starting their 3rd year of medical school.
Awesome. Thank you, Carrie.
Mm-hmm.
Appreciate it. Good job.
Thank you.
Yeah. It might be helpful maybe to have your results slide up with the graphs and the numbers and all that. I think, and then if you don't mind, and then I'll open it up for any comments or questions or anything that people want clarification on. This will be helpful as Carrie is strategizing how to best present findings going forward.
One question I had for people was if there were specific like variables that were more interesting to them than the ones that we picked out. I mean, it's kind of a like choose your own adventure results and conclusion write-up because it's just but it's a descriptive study. So the ones that like stuck out to me were the ones I mentioned about incarceration and delivery mode. But if there are other things that were more interesting to people, even if not like as even if not like as statistically significant.
Can you go to the next slide with the ones that you had? Yeah, this one. So that's a good question.
Hello, this is Deshonda Taylor. I just wanted to say great presentation. I like that you mentioned that people were more stable on a certain dose of Bupe. I think that was an interesting finding, and I was glad that you highlighted that. But I don't have any other comments at this time. But good job.
Yeah, I have a question, because I am not a clinician yet, but can you talk kind of like about the difference in dosages and how that relates to patient care and any potential conflicts between the dosage in patients, like side effect wise and things like that?
I can start, but I'm definitely not as up to date on everything. But historically, the max dose was 24 milligrams. I don't know if that has probably changed because I see patients on more than that, more usually than I used to. But we usually just go by withdrawal symptoms or cravings as far as determining if people need dose increases or decreases. And then many patients who are pregnant on buprenorphine need like split dosing because of the way they metabolize the medicine. And so it's sometimes like an 8 milligram TID dosing, and then that can transition to like 12 and 12 postpartum. But I defer to Dr. Martin to talk more specifically about maxes and stuff.
Yeah, you're right. The 24 is still like the state reg, but we can submit prior authorization to get it above 24. Sometimes it's hard. Well, a lot of times it is hard to do that for patients when they're not pregnant anymore. It's easier to just get that approved. So to that question. The other thing to know is that this is just an observational study. We can't draw any conclusions from what the dose changes would impact. We're just describing like what people look like. So who did those things that we had data for? So the decrease in dosage group, like the small group in the green line on the graph, those also might be people that were choosing to taper themselves. So, right, because obviously they're going to decrease their dose if they're tapering. So it would make sense that they also then would stop because they were tapering off. That's of course not a clinical recommendation that we make for patients. We recommend that when they're on Suboxone, that they continue it through at least a year postpartum, but at the same time, that's still a shared decision making and people have autonomy and can choose what they want to do. So does the buprenorphine stop, that you see more commonly in the decreased people mean bad things happen to those people more often than the other patients? We don't know. It's just more likely that they stop their meds, but it also just might be that these people were choosing to taper. However, we all know that people clinically will taper their buprenorphine a lot of times because of external coercive factors. So, but we don't know that about these patients. That's just me speaking clinically and what we see.
Hi, Sorry, my camera's been off. I've been eating. Nice job. I had two questions, and I am not a researcher, so if these don't make sense, please forgive me. I am definitely a clinician and not a researcher, so I'm the flip side. But related to dosage, I just wondered if there were folks included in this study who actually had a request or a need to go above 24 that were like turned down by insurance, and are they included in any way here, or did you have just any observation about that? And then my second thing, as far as variables that you picked out, you mentioned incarceration, and I am squinting because my glasses are elsewhere, as far as whether they, how many people stayed on the medication and at what dosages. But I wondered about other more restrictive or controlled settings, like our folks who are in a residential treatment program, et cetera, and therefore somebody is kind of monitoring whether or not they're taking it and more aware of symptomatology, as well as follow through.
Yeah, Dr. Tyson, for your question about the above 24, we don't know that. We didn't document that in the database. However, this data is all from like 2017 to 2020, and anecdotally, we just were not submitting prior auth. I mean, it was very rare back then because that was pre-fentanyl.
Gotcha.
So I don't think it would be a big thing because this data is a little bit old. Now, if it was today, that would be a different situation because the fentanyl era that we live in. But that's a really good point, because if we do end up repeating an analysis like this, like with Medicaid claims, for example, which I would like to do, we would have to take that into consideration if we did that today.
Well, and I would think, when you mentioned like future directions for study or what you'd like to do with this, individualizing that conversation, encouraging people to, be very individualized with their approach. I would also hope that one day we could use that information to get insurance companies to stop capping at 24 and, have some data to say, this is how often, just observationally, we are requesting that possibility, because there's actually a clinically documented need, whether or not we're able to do it or not, it's being recognized as we are under treating them, and we all know that's a risk factor. So
yeah, that's a really good point. You're making me think, because some states don't have the 24 cap, so if there was a way to look at data across states, that might be one way to look at the going above the 24 cap.
Would it be in the claims if it's a prior auth?
I don't know, Hannah. I don't know.
Hey, Carrie, great to see you. Love your presentation. Fantastic. Anything that gets the neurons going. I was just curious about if there was any look at open CPS cases or not postpartum. We tend to see a lot of times, or we hear patients that, that can be a driver for staying on medications initially. Just wasn't sure if that was something that had come up.
That's a great point. I don't think we looked at that, but that's probably in the data. Yeah.
That's a really good point, Margie. I don't think that's in this database. However, in the postpartum recovery data, what I've told Carrie is that I anticipate us potentially like not merging, but looking at doing the same analysis that she did in that small cohort. Like that was just such a small number of people, just because we got so much data in the postpartum recovery people, because that wasn't chart abstractions. That was like literally asking people a lot of surveys and a lot of questions. So that's something we could delve into in a different database. We just wouldn't have the sample size to draw any conclusions, but it might supplement the data that Carrie has here with a larger sample. So that's a really good point.
Hi, Carrie. Such a good presentation. Good to see you. I was curious if you could speak a little bit more to the admitted to the NICU variable. As someone, like I'm currently a therapist in the NICU right now, and I work a lot with, new moms with substance use disorders. And I know just, anecdotally, like the NICU is such a stressful and challenging time, and it definitely challenges women in their recovery. So but that's from the therapist side of things. I'm just wondering from the clinical side of things, like what you thought like might be happening when you were looking at this variable.
Yes, that's another great point. I think I guess the like overlying theme is stress added in the postpartum period, stress and pain added, and how that intersects with people's substance use disorder and need for treatment. It's just so hard because you can't really parse out if someone's increasing their dose because their substance use disorder is getting worse, or because they're like more appropriately treating it, or because of all the other stuff they have going on. So it's hard, obviously, which is why the job is challenging. But as far as the NICU, I think, yes, my thought behind that was that patients who had babies admitted to the NICU would probably be more stressed and therefore maybe require a higher dose. Another thought is that parents who are in the NICU may be like more, I mean, some of them may be around the hospital more, so more able to go to appointments, but also some may be less able to go to appointments because their baby's admitted. So it's hard to say like exactly what it means, of course. But my thought was mostly like the stress that accompanies a NICU admission.
Yeah, makes sense. Thank you.
And that's a good point too, Carrie, because in the few studies that have looked at overdose rates, for example, in the 1 year postpartum period, variables like NICU admission, for example, or treatment for NOWs, which used to have to be in the NICU only back in the day, that has popped out in some studies in other states as being an identifiable factor that's associated with elevated overdose risk in the postpartum period. So definitely hinting at that extra stress of what you just said, and how that might be a hypothesis of the connection of that association.
Yeah, and those things also intersect with increased risk for postpartum depression as well. So it kind of all comes together. Makes sense putting them at that heightened risk, definitely.
Hi, Carrie. Can you hear me? My internet has been very bad today. Still bad. I just on that note, I think it's important to highlight the NICU admitted in the way that you are talking about, and the way that I know that you know. But I think reviewers or people reading this could say something about the people being on higher doses initially, then having the baby more likely to have NOWs, and then admitted to the NICU. So since it's not causal, it's just observational, I wouldn't want someone to interpret this and then use it against our patients in the way that I have no concern of you doing that, Carrie, but just like for everyone to think about the way that these data can, especially when they're observational and not causation, it's just like people could interpret it either way.
And Carrie, Annabeth also put in the chat about mental health variables. So I know you have psychiatric comorbidity there. So something else that you might be able to do is use the variables that Hannah did from her prior paper of receipt of mental health treatment, the behavioral or the medication, around that time frame that you're looking at, if that's possible. So that would be another thing to add potentially.
Thank you, guys. This is good food for thought.
Any other feedback, questions, or thoughts that people have?
I have one other clarifying question, and I might have missed it earlier on, but the monitoring, is it a change that happened at all during this 3 months, or was it at a specific, it wasn't like at a specific, 4 weeks after they had a change, or it was just any change throughout? Is that right? Okay.
Well, great. This has been really helpful. Thank you everyone for your feedback, and great job, Carrie. Good job. It looks great. I'm excited that again that this is being presented at ACOG. To get some more press. At ACOG this year, I will say there's multiple symposiums or symposia, I guess, that got accepted at ACOG this year on buprenorphine. So I appreciate that ACOG is spending a little bit more time and effort on this topic. So I think there's like 3 I know of. And they're also sponsored like a pre-conference course thing that we're doing. So, and there was more than one abstract on buprenorphine. So I like that ACOG is starting to spend a little bit more effort on this, which is really good. So your abstract being accepted is an example of that. Wonderful. Well, thank you everyone so much for coming out on this lovely Wednesday evening. And thank you everyone for your comments and feedback. And we look forward to seeing you next month at the next meeting. I will see everyone back then. Bye.
Bye. Thanks, Dr. Shadowen.
Bye all.
Really good to see all of you,